Test. Okay. It's good. اوكي رادي الحين. تست انطفى هذا. تست هذا فصل. تست. اوكي. ابلش. All right. Good afternoon, everyone. Good afternoon, everyone. So I'm glad to be here today to talk to you about advanced technology in the field of dentofacial deformities and how to correct them. In the field of maxillofacial surgery and orthognathic surgery specifically, there is a lot of technology that has been coming on in the last few years, but specifically I'm going to touch upon certain part of it. So I will talk about facial scanning in that field, but I'm going to go ahead and go directly to the last message. The take-home message that we want from the lecture, that planning of orthognathic surgery is a comprehensive procedure. You have to pay attention to all clinical details when you start planning for surgery, and you have to seek the knowledge of advanced technology and trying to find out how to get the best technology that is out there, test it, attend courses and workshops to bring the best for your patients, and pay attention not to pay attention to speed only. You have to focus on performing a thorough examination. So that's the take-home message. From there, we're going to depart. So let's go ahead. It's disconnecting. All right. So specifically, I'll be talking about facial scanning, and it's used in maxillofacial surgery. A three-dimensional facial scanning is considered a new technology. We've been doing a lot of imaging using conventional X-ray imaging, such as OPGs, lateral ceph, CT scans, and we've been relying on on hard tissue analysis in order to decide what we want to do for our patients in terms of correcting dentofacial deformities. But now, with the advent of recent technology, we can use facial scanners to look at the soft tissue and plan from the outside in. So try to go to the goal. The goal of correcting the facial profile, correcting the facial proportions, focuses mostly on the soft tissue. This technology has been used heavily in the field of gaming, in movies, in forensics, anthropology, archaeology, and cinemology. In terms of medical applications, we've been lagging behind. So look at the Avatar movie. How many years it's been? Many years. And in that movie, they utilized facial scanning, and they utilized facial recognition, and they modulated that into 4D animation in order to come up with a predicted face and use it in the movie. Again. So that has been used also with time dimension, in which the facial scanning was augmented with augmentation reality in order to predict movements. In the field of archaeology, you get a soft tissue, a CT scan of an archaeological specimen, and from that we try to predict the soft tissue profile. We can use soft tissue facial scanning of a similar soft tissue envelope and try to superimpose the coloring on top of that. Now, in terms of face recognition and in the forensics field, this is being used heavily, and we're using some features now in the medical application, same features that is being used in the area of forensics. We are applying that for artificial intelligence and the field of maxillofacial surgery. In the medical field, it's mostly being used in our field in plastic surgery, in maxillofacial surgery and orthopedic surgery. So for the treatment of scoliosis and assessment of deformities or the vertebral columns, 3D facial imaging is being used. But in the last few years, you have also 3D printing. So we were able to augment the use of 3D facial scanning in addition to 3D facial printing to come up with something more innovative. For example, now for sports, we are able to fabricate masks that are custom made to the patients based on CT scan, based on facial scans that are taken in the clinic. So you take a facial scan of the patient, you send it to the 3D printer, and you can print a facial mask for sports. Same thing, you can duplicate the face. You can print the face in 3D, in colors, using the appropriate 3D printers if you have an appropriate facial scanner. So the field for utilizing facial scanners seems to be vast. And in the field of surgery now, we see that there are a few applications and several applications actually coming up in the recent years, focusing on digital smile design and incorporating facial scans from the outside in order to come up with the right dental rehabilitation. So in this case, it is a mobile application. You take a facial scan of the patient. At the same time, you use a scanner to take intraoral scans and augment them together, trying to come up with a 3D model. And based on that, you can decide on the crown length and all of that, even the color and the morphology of the crown. So it's coming up to dentistry, and here I'm going to focus on our field in maxillofacial surgery and how we utilize it to increase the efficiency of our surgeries. So the way we're going to use facial scanners in our field is to simulate the treatment, to predict the treatment and simulate the outcome of the treatment, and then we can use the scanner to take pre-operative photos, we can take post-operative photos, and combine them together in order to measure the differences. So here, for example, we call it heat map. So here, this is an imposition, superimposition of a pre-operative 3D image on top of a post-operative 3D image, and based on that, you can come up with lots of studies evaluating the differences. So the technology that is being involved has been under constant development since the 40s. And you will come across different terminology, such as stereophotogrammetry. There is image subtraction techniques. There is the Moire topography, liquid crystal scanning. So the technology, it keeps evolving, but the basic goal is the same, that we want to get an accurate sub-millimeter resolution of the face. So in our field, in dentistry, in surgery, we use these three technologies: structured lighting, stereophotogrammetry, and mobile facial scanning applications. And I'll go through all of them in detail. The structured light, it projects light in order to capture an image. Stereophotogrammetry is based on photos taken from different places, and mobile application is based on an algorithm that is able to extract data. So structured light, again, requires a projector. The projector projects the light in a pattern on top of an object, and then you get the reflection being measured by a camera. Based on the deflection of those light sources, we have an algorithm that it will calculate all of that. Based on the distance, it will estimate the 3D surface of an image. So active photogrammetry is a pattern. When you project a picture, you have two images, you have two cameras simultaneously capturing those images or the deflected lights. And there is something called passive. The passive stereophotogrammetry, you have cameras, high-resolution cameras, without a light without a source light coming in from a projector, and based on the resolution of the multiple cameras, you have an algorithm that combines all of them to come up with a final image. So many technology that are coming up in the past few years. The best technology that is available right now for us is the hybrid stereophotogrammetry, in which you have cameras, multiple cameras taking multiple high-resolution images. At the same time, you have a light source that is projecting a pattern. At the same time, it gets passively recorded by the cameras. So there is many cameras, the technology is there, probably you cannot read that, but about all the feature, and then you can look at the price, 13,000 euros, 27,000 euros, 9,000 euros, 20,000 euros, 37,000 euros, and there are cameras up to 100,000 euros. So what we know about these camera systems, that they use all different technologies, and the price keep getting, even though it's getting more affordable, but it's still very expensive. So I'll go over a couple of examples. This is the Axis 3 camera from Belfast. It is used in the field of maxillofacial surgery, plastic surgery, both for the face or for the upper part of the body. It projects structured light, and you can see the light. They come up, they get projected in colors. You can capture 100 degrees of the face. It takes less than 2 seconds to capture the image. Each image is about 3 megabytes in size. And the price of this device is 13,000 euros. Next is the 3D MD. This was developed in Stanford in the USA. Now the headquarters is in Atlanta. It's the same thing. You have multiple cameras, 6 cameras, sometimes 3 cameras. It uses active and passive stereophotogrammetry. You can capture 190 degrees, 1.5 millisecond for the image, 3 megabyte. Price again still more than 21,000 euros. The next one is the one that we have at Kuwait University. So this is called Vectra H2. On the left side is the H2, on the right side is the M3. It's produced by Canfield, USA. It's also the same thing, the same concept, but here we have 2 different technologies. You have the multiple cameras being set aside, and then the patient sits in the middle, in which multiple cameras take pictures simultaneously. So these are multiple cameras, single shot, or if you don't want to pay that price tag, then you can take the same camera, but you move around and take multiple shots with a single camera. Now, in terms of pricing, it is still, that small camera is still $10,000. That one is still $26,000 and euros is the same now. So it is a pricey device. But what can we do with this technology? So let's go ahead and look at how it works. So this is a device. It comes with a working station and a chair. Multiple cameras are installed. I have to sit in the middle. You ask the patient to look straight ahead. The picture takes less than 2 seconds or less than 1.5 seconds. Then multiple images are taken simultaneously and constructed into 3D image. Now, this is a high-resolution image in which you can utilize the screen as an iPad with dual touch. You can enlarge the image. You can magnify into it. You can look at different perspectives, and then you can use artificial technology to look at the cephalometrics, the soft tissue cephalometrics. Look at here, the alar base, the medial canthus. We can go into assessment, so you cannot read here, but you can say, let's go about assessing, for example, facial proportions. You can look at the facial proportions that we're talking about, like how many portions of face, what is the percentage. Here I'm superimposing the right on the left and the left on the right. So my face, if the side is duplicated. That was the facial proportion, the anterior fifth. I can look at the nasal angle. I can look at the dorsum. Pretty much you can evaluate the cephalometry of the soft tissue of the face in complete detail. Then you can go, look here at treatment simulation. I don't know, look at my nose. I'm trying to manipulate the nose for rhinoplasty. Projection, under projection. Based on the AI that we have, you can play around with the points and predict your surgery. Let's go now, probably I'm going to the chin. So at the chin, frontal view, you're not going to see much, so I'm going to flip back to profile view, and I'm going to do genioplasty, projecting the chin, enlarging, reducing, up and down. So using artificial intelligence, we can use this as an envelope, as a soft tissue envelope to predict procedures that we do. And then you can use an algorithm or export that into a treatment plan that could be taken to the OR. Now, if you cannot have that machine, you can get this Vectra H2. It's another machine, but this is single camera. So a single camera, you just have to position yourself according in a 3 positions so that you capture all of those images that we got before. But at this time, you have to move around and take pictures. This is our colleague, Dr. Ali Akbar. Now he's doing his residency in the States. I asked him to take pictures of him, and he allowed us. So the images are taken from different areas, combined together using the same software, exactly the same software, same resolution, and then you can go ahead and do the prediction exactly as I did with the original camera. Now, what about new technologies that are coming up? We have the mobile scanning applications using iPhone. Remember that starting with iPhone X and after, or with the Samsung, we have true depth cameras. The true depth camera in the front camera of the iPhone allows you to do the face detection. So the Face ID that we're using in the phone, it's based on that true depth camera. Using that technology, you can do something called taking pictures from motion, so structure from motion, SFM. And based on that, you can come up with a 3D picture. Now, how good is that picture? Let's go ahead and have a look. There are several applications now, still many under development. I'm also working with an IT to develop our own facial scanning app. Let's go ahead and see how it works. So I'm going to run that. This is a camera. In front of me, I'm sitting in front of the camera taking a picture of myself. The camera is on the top, and let's see how it works. It's saying, look at the camera. الصوت رايح, مفروض إنه في صوت. So look at the camera, turn your face to the left. So the phone is telling you, the app is telling you, turn your face to the left. Then it tells you, turn your face to the right. And then it tells you, turn back to the middle, turn up, and then turn down. All of this takes less than a minute. It's done in the clinic. It's processed simultaneously. And based on that, you have a 3D image that you can also do the same thing. Enlarge into it, utilize it as a 3D reconstructed image, and use that also in the treatment planning, either to superimpose it on cone beam CT images, because the cone beam CT has the external soft tissue, but without colors. Look, this is a picture that was taken in less than a minute. In this app, for example, it tells you, okay, now you can export it, pay $1 is going to get exported. So I'm going to go ahead and export it. And let's see what's happening. I have it on my working station that I used to do orthodontic surgery planning. That's the same picture that I took in the app. After a minute, it's on the computer, and I get all these 3 pictures. This is a continuous 2D image. A 3D image is based on a continuous 2D image. Exactly how we look at the world map in 2D. This is how it is called continuous textured, and you can use that in lots of programs if you cannot utilize the 3D images. But the STL files, the OAG files, are in your hand, and those are the files that allows you to evaluate 3D structures and look at things in 3D. So we have many publications about that. So this is our recent publication about the accuracy of low-cost facial scanners in comparison to the $30,000 scanner. And it seems like in our hands, in our work, things are positive with these devices. The only thing you have to worry about is the patient privacy, not to get any application. There are just a couple of applications, not many, but you have to worry about patient security and privacy of information. Then you have intraoral scanners, and this has been around for a bit longer time. The 3D facial scanner in this shape, in this case, is 3-shape. This is what we use at Kuwait University. I have no affiliation with the company, but having now the ability to do external facial scanning and the ability to do intraoral scanning, we can combine them together, and we have a true 3D model of the face and the intraoral cavity. So with that, I can say the orthodontic surgery that I'm doing now, it is all impression-free, plaster-free, no impression, no articulator, nothing else that needs to be taken except of doing these things properly and doing every step meticulously. Intraoral scans, you get digital cast. 3D printers, you get high resolution printed cast. Digital facial scans, you can look at the external part of the face. The digital surgical planning, that depends on your software and your diligence at work. 3D printing, again, you print the resolutions, the high resolution splints, you take the patient to the OR, and you do the surgery. At the same time, you can predict your simulation, including the soft tissue of the face. For example, this is a patient was sent to me by my colleague, Dr. Faraj Babahani. This patient was appointed as a pilot at Kuwait Airways, and he wanted to start working after a month. He wants to do surgery first. Class 3 deformity. He doesn't have time to undergo surgical orthodontics, pre-surgical or pre-operative surgical orthodontics, and we wanted to go ahead and do the surgery within 10 days, and after that, he will deal with the post-operative orthodontic work. So I had to do 3D planning for this case. So a proper clinical photos, a proper vertical natural head position photos. Look at the red line. This is very important. This is very important for my planning, having a line in which I rely on the patient to look at their exact 3D position. The face is floating. No matter how the patient stabilize himself, the face is a three-dimensional, in a three-dimensional space. It moves into different direction, and even with each picture that you take, you cannot repeat the same position easily. I'm talking about normal patients without having torticollis or any other conditions. The regular patients cannot align their head easily, so you have to guide them. We have to think about the pitch, about the row, about the yaw. You have 3 movements in the head that will dictate the final head position. You cannot plan surgery based on a picture like this. You have to standardize everything that you're doing in order to take an appropriate picture. So here I have, for example, a string that is attached to a weight. It allows me to know the vertical position, the true vertical. Then the patient has a mirror in front of him and trying me and the patient to align the patient appropriately in front of the mirror in relation to the natural head position. Then I take the picture, and based on that, I know the profile, how it looks. But usually the patient doesn't stand like that. But when you find out the natural head position, this is the natural head position which you have to use in order to do the complete planning. Let's go ahead, and now I have intraoral scanning using a 3Shape. I have the facial scanning that I don't remember whether I took it by the phone, by iPhone, or by the Vectra camera, but it doesn't matter. It's appropriately taken 3D cameras. So 2 of them, I make sure they are high quality, good resolution. They both look good. Then I will use this to construct the skull of the patient, and based on that, I can do my analysis and proceed with the treatment planning. And for that, I have a special software. The software is from KLS Martin Company, and I use it to import all the information inside. Based on that, I measure the angles, add all the clinical data that I collected before, and based on that, I can come up with a treatment planning. So, for example, I want to do a maxilla, a mandible, and based on that, I can construct digital splints. So digital splint, this is just about the information if anybody wanted to know. This software is called IPS Case Designer. You can get a license for yourself, a license for the hospital, license for academic. They also give you free trial for 90 days. Now, this is a simulation. So I did the surgery. I still haven't done the surgery. I did the surgical planning. I used the soft tissue picture that I took to predict the planning. So I superimposed the image on the CBCT, I did the planning, and then projected that on the soft tissues that I have of the patient, and now I know this is what I have for the patient, how the patient will look like. So this is my surgical planning. How accurate is it? We're going to go ahead and find out. So 3D printer. This is a 3D printer called Anycubic. This is what I use. I ordered it from the internet. It's a very good printer of high resolution. It's enough to do the work that I wanted, to print skulls, print mandibles, print splints. Anything more than that, you have to talk about higher resolution printers. And 3D printer, the concept is pretty simple. You have a platform that dives into a resin, and then light source projects some sort of light that will help the material get cured. So here it's LCD, with this printer LCD. There is something else, another printer that uses laser. There is another printer that uses structured light, but here it uses LCD, and it goes down, the lights get projected at each layer. So each layer, it's like the old printers that we used to have, the DLT printer, but this is a 3D printer in which layers come on top of each other. Now let's look at the end. It's printed vertically. We don't want to distort the occlusal surfaces. This is our colleague, my colleague, Dr. Ali Akbar, before he traveled to the US. And then we sat in the evening after the clinic. Then you have to put it in alcohol. The machine will wash the splint, and then the splint will be ready to be prepared. Now, these extra things, you see them in the plastic toys. If you see plastic toys, you see some little dots of plastics at the end. These are the struts that are used to print the plastic material. Then you put it under the light. It's called curing, similar to composites or whatever we're using in dentistry that needs light curing. Then it is cured. Now we can remove it. We can cut it. We can remove all the extra pieces, and it is ready to be disinfected and used to guide you in the surgery, just to position the maxilla and the mandible in the right place. Now I'm printing this color. I was trying this color of resin, but there are many colors of resin. This is, look at the quality of the 3D printing. Look at the wire for orthodontic wire. It is printed in 3D. So now I don't have to put wax on the brackets. I go ahead and do 3D scanning. I print the cast. I print the splint. And here I have something interesting. I designed a model, a plastic model that goes on top of the splint, in which I can cut for this genioplasty. You can do the osteotomy, the cutting guide for osteotomy. So this one, during surgery, you put it on top of the splint in the patient mouth. You rely on the position of the teeth and predict how you're going to cut your cut, and actually guides you how to cut. Here, for example, we want a 3 millimeter impaction, so you cut 2 cuts according to the guide to make the osteotomies at the right level. Now let's look. These are actual photos. These are not predictions. This is the patient before surgery. Let's see. It's because of probably the file size is big. So this is 3D after surgery, and that's supposed to be 3D before surgery. It's supposed to run simultaneously, but because of the memory of the computer. So before surgery, you can look at the class 3 profile of the patient. After surgery, we had, this is actual photo. I also tried to do it as video simulation. You can clearly see the accuracy of the planning and the accuracy of the treatment are both matching to each other. I apologize, they're supposed to run together, the videos, but I think because of the RAM with the computer, that's not possible. This is another case that we have done. This patient also class 3 deformity. And we can look, for example, the profile before and after. This is all before, sorry. These are all before. This is before and before. Smiling. And this is before profile smiling. And this is the prediction. Now, I didn't superimpose it. I just want to show you what's going on underneath the skin. I can add the facial scanning on top, but I want to show you that the CBCT has soft tissue envelope, but without colors. So when you take a 3D facial scan, you put it on top. Here, we advance the maxilla. So based on my planning, I decided aesthetically, for this case, better to do advancement of the maxilla in order to achieve proper occlusal relationship and proper aesthetic result, having more projection of the tip of the nose, rotation. So when the tip goes up, we call it rotation of the nose. And then you have better support of the nasolabial fold. So I decided that the the patient will undergo only a single jaw based on the planning. Without that, we would have gone to the conventional treatment, which is advancement of the maxilla and setback of the mandible. But when you have a proper 3D picture of the patient, I'm talking about the soft tissue, then you can predict every move, then you can take more radical actions and rely on a single jaw surgery to come up with the results. So advancing the maxilla and relying to advance the whole nasal complex to get an improvement in the midface. So let's look at the pictures. Same patient, same view. Pre-op, post-op. Increased teeth show. Look at the nose, you cannot tell much, but the nasolabial fold, you can see there is a bit of improvement. On smiling, now you see the nasal tip is going downward here on the left side, pre-op. Post-op, we can see the nasal tip is in a better position. Now, on the lateral side, you can see that how this mid-face improvement can be greatly seen using only advancing the maxilla, advancement of the maxilla without touching the mandible. So we kept the mandible in the same position, just advanced the maxilla, and even the nose, you can see there is some improvement in it. So it tells us how the soft tissue behaves to some extent, and it allows you to post-operatively evaluate the patient. So this patient, the picture now is taken how many? So maybe 6 months after surgery. This allows me to look at the symmetry of the result, and then allows the same picture to be compared to the pre-op and look for, in terms of research, you can compare them and predict the movements and what is the tissue response to your movements. So this is what I've been using the facial scanning for. Here, this is another patient, class 2 deformity. Again, we are gonna do mandibular advancement. For every single case, I use the same protocol. I don't switch between normal protocol to advanced protocol. So every single patient received the same full digital workup. Everything is planned from 3D facial scanning. The patient comes in, CBCT, 3D facial scanning, conventional photos, intraoral scanning, clinical exam, and we're done. We target that to be done within 90 minutes. And then, same thing, prediction of the hard tissue. We're going to improve the gonial angles if we advance the mandible. Look, if we advance the mandible, that's about 10 millimeters, 11 millimeters advancement. Then you have improvement of the chin, improvement of the gonial angle. There is no need to touch the maxilla at all. So let's look at the other picture. Now I transfer this into soft tissue prediction. This is again from the RAM of the computer, because it has to. So same thing, before surgery, simulation of the surgery, before surgery, simulation of the surgery, and then we come up with a new algorithm. The more surgeries we do, then we can go retrospectively evaluate the actual response, and we put it in an algorithm so that our prediction becomes better in the future. So this is what artificial intelligence is about. Doing something and keep working on improving it. This is the last patient that I did a couple of weeks ago, and the picture was taken yesterday or the day before. So this is pre-op. The patient came to us. Same thing. The patient is complaining now of a gummy smile. And a class 2 deformity. Look at the chin. Same thing. The picture was taken natural head position. Look at the intraoral photos. This referral was by Dr. Ala Jamal, our colleague. And the same thing. Then I go ahead and do the complete workup and 3D simulation. So of the surgery. From the front, you cannot tell much. From the side, a little bit of impaction, a little bit of advancement of maxilla, advancement of the mandible. And in this case, the decision was not to do genioplasty because the soft tissue simulation showed us that it was adequate. So this is the prediction. From the front, you cannot tell much. Again, the RAM issue, memory issues with the computer. Now, 3/4 view, look at the, okay, this is before and after. You cannot say, this is major change, even though it doesn't look much, but it is a major change when you have advancement and impaction of the maxilla. Now, I asked the patient the day before, yesterday, to come so that I take the picture once again. So this is a pre-op. This is a 3-op, non-smiling. Look at the profile. ما راح أشغلهم مع بعض نفس الوقت الحين خلاص. إنزين. This is post-op. Less than 13 days after surgery. Less than 2 weeks. Now, almost the same prediction. Now, the gummy smile is going to be improved, but keep in mind, because we did incisions in the upper lip and the vestibulum from the upper lip from the inside, then expect this, the on-smiling, still, there is not full dynamic movement of the upper lip. So, this is a gummy smile before surgery. You have to pay attention to the mandible as well, because she was class 2. And this is now at 2 weeks, less than 2 weeks after surgery. And in a month's time, the lip will keep going up, and we will reach the final goal of having this gummy smile from 4 millimeters to 1 millimeters. I tend not to do much impaction of the maxilla because a bit of gummy smile is pleasing to the eye. It gives the patient the look of being younger. So despite what the patient tries to convince me of, that they are not happy with the gummy smile, I do only 50% of what they ask for, because having a bit of gummy smile is pleasing to the eye and is a sign of cosmetics. So this is also a work that I've been working on, trying to augment virtual reality and use it in the field of maxillofacial surgery. So this is, we took the CBCT of patients, and we are able to use the VR cameras, so augmented reality cameras, and with the handles, you can dive into the CBCT and the CT of the face. So you can go all the way to the mental canal, mental nerve. You can enlarge, and you see yourself in front of the mental canal. Any structure. In this case, this patient has squamous cell carcinoma of the tongue. So you cannot see the colors now. We can color it. But the thing is, we enlarged, and we went through to the tumor. You sit in the middle of the tumor, and you move your head. You look at the tumor from a three-dimensional point of view. You look at the mandible, you flip it. So this is what augmented reality is about. But this is not pretty advanced still. So let me see. We published this, the virtual reality in pre-op imaging maxillofacial surgery. We published that, when was that? That was a long time ago, 2 years ago. So this is augmented reality. And now we have something called mixed reality. So in the mixed reality, you have, we use the cameras before, or something to cover the face with the eyeglasses, but now with the mixed reality, you can have it in front view mixed with the reality. So you don't have to wear a camera. So you can utilize data and use hologram to project the information in front of you here. So this surgery was done while I was in Germany, and we came up with a CBCT scan, had a hologram machine in the OR, and then using the mixed reality to project the 3D structure of the surgical procedure that we're doing simultaneously in 4D. So we're cutting the maxilla. Here the maxilla shows you in front of you and in a hologram that it is being cut. And that is mixed reality. We're heading into that direction, not the augmented reality. The augmented reality is the gaming technology of the 90s. So now we're going straight ahead into mixed reality and very advanced technology. This study has been published a couple of months ago. So most important thing that we are using all of this to come up with higher accuracy of our planning. This should be your focus. Deliver the best for your patient and the highest amount of accuracy. Let's go into the story of Robert Liston. Robert Liston is a British surgeon. He used to be famous in his time. He was the fastest surgeon in his time doing above knee amputation and below knee amputations. So in the past, the patient had diabetes or something, they had to amputate the leg. So surgeons used to brag how fast they used to do the amputation. And the faster, because it was a pre-anesthetic era, so the faster you did it, the better you were. He was the first professor of clinical surgery at the University College Hospital in London. He performed the first public operation utilizing modern anesthesia in Europe at that time. So that was pre-anesthesia and using anesthesia for the first time in Europe. There is a quote about him that he had the fastest knife in the Western world. He could amputate the leg in 2.5 minutes. There are many books and articles about it. Now, what did this guy do? We have to pay attention. The best surgeon in the world, what did he do at that time? So, he, in his last few years during work, he had done his most famous case. The most famous case, he was trying to show the surgeons coming from Scotland how fast he was doing the procedure. He amputated the leg in under 2.5 minutes, and he was trying to do that at a faster rate than at 2.5 minutes. Of course, that was an achievement. If a patient died, that was common during that time. So he amputated the leg of the patient. The patient afterwards died in the hospital. So that is okay, acceptable. But after that, at the same time, because he was running so fast with his saw, he was going so fast trying to achieve his goal, he amputated the fingers of his young assistant, who also died afterwards from hospital gangrene. At the same time, while he did the cut, after cutting the fingers, he also cut the lab coat of a spectator who was standing there as well, who also died afterwards because of shock. So this surgeon had probably the only guy who had 300% mortality rate, well documented in the literature. And this is exactly what we want to try to avoid. Fast surgery is a good thing, but the most important thing is going into accuracies, knowing exactly what you're doing, paying attention, go over it again and again, having a bit of OCD, trying to do your clinical exam twice. Better to have somebody do it for you and you do it on top of it to deliver the best of your patient. And then never forget your artistic touch. You have to look and evaluate everything in a three-dimensional form, but at the same time, everything you evaluate has to be evaluated in an artistic way. And then when you go to the OR, you have to take your time, if you can, sit and enjoy what you do, and do that slowly and carefully. Thank you very much for your attention. This is Ibn Sina. So the first thing we did, I tried to do that in a 3D. So in a 3D format, sculpting that in a 3D format on iPad, learning how to sculpt in 3D. And then from that, we put that aside and try to do it in reality using clay. And it helps you a lot. This practice probably, I used to carve, so carving wood, but this molding has helped me a lot understanding the facial structure. I always thought that the head is rounded until this time came, where it is, I found out that the head is an American football plus a regular football on top of each other. This is just phenomenal, trying to know how the anatomy of an artist is different from an anatomy that we think of in a clinical setting. Everything I was doing in the beginning, an artist was telling me that you are wrong. What you're doing is wrong. So I had a professional artist with me. He was telling me this is wrong. I know you're a surgeon, you're cutting it this way, but no, artistically close your eyes, close one eye and look with the other eye, and this is how it is. So I learned a lot from this, and I recommend all of you to dive into this experience as well.
Thank you so much, Dr. Mohammed Kamali. Please give it up for him. Thank you for showing us that the VR is not for gaming, and we're going to see that the future of
the VR is old. Now the mixed reality should be coming up.
Thank you, and we're going to open the floor for questions. I have a question for you, Doc. How much does facial hair affect the scanning? So if someone with a bushy beard comes to you, do you ask them to shave it off? Or?
Yes, definitely. So all of these guys that you saw, they usually, it's a trend now to have the beard, yeah. So everybody now of these patients, usually they come to me before surgery. I tell them to come back again, shave, يعني not more than 1 millimeter, and then take a picture. The hair, you will have defects in it. Now you can have another software trying to fill the defects, but heavy hair, probably I can do it for you. This is not considered heavy hair. So I can do you facial scanning, but anything more than that, facial hair, it will be difficult to capture and you will have a defect. Females, it's always possible to take good pictures of them, but with the facial hair, it is difficult, except for the mustache. The mustache is acceptable because the way the picture is taken, it allows the mustache to be captured. It is just the hair in this part of the face that has to be of a less amount.
So you would ask Ibn Sina to shave then?
All of them, I've been asking them to shave or to shave before surgery, and when they came after surgery for follow-up, I tell them, call me whenever you shave so that I take a picture of you. I don't force them to come on a certain day. I tell them to come whenever they shave and to take a proper picture.
Thank you, Doc.
Yeah.
Any questions from the guests? Well, thank you, everybody.
Thank
you, Dr. Muhammad, as well. We're going to thank you, appreciate it for all of your efforts for today's lecture. We'd like to present you with this.
شكرا الله يعطيك العافية. وين؟ Thank you. يعطيك العافية. مشكور ما قصرت. Thank you. Really appreciate it. Yeah.
It was honestly really
I'm glad that you got like.
Thank you, everyone, and we're going to start the next lecture at 5:30.
Thank you. مع السلامة. Test still up.